Can you see the presentation?
Yes.
Perfect. So then we're going to go through. Okay, so first of all, just a little bit about my background. We have a practice, our main practice is in Hamburg, situated in the city, and we have in total 3 centers around the city. The main practice is here directly in Hamburg, downtown. Then we have another place a little bit more north and directly north to the airport. These are our 3 practices where we do the conservative treatments, and we treat more or less 30,000 patients per year. And then we have our hospital where we do more or less 3,000 surgeries, interventions. And in all of our 3 practices, we use ACP, we use a PRP from Arthrex, and now more or less 1,200 injections, plus the ones we use in the hospital, but I don't know the number here. And the main topic a bit is to explain you why we use ACP and where we use ACP, and just a little reminder what that is. So when you take full blood from the patient and put it to the centrifuge, you're going to separate the parts of the blood, and what we want to have is the plasma. And main part of the plasma are the thrombocytes, as you can see down here. And due to the centrifuge, we are going to activate these thrombocytes, and through these little feet, through these Filopodi, cell-free plasma concentrate. And what we know is that we have a lot of growth factors which will come out from these thrombocytes, and which are able to help us in healing. What we know is that these growth factors promote cell proliferation and tissue regeneration. So what I'm going to show you is how we used it in our daily life. So how we use it preoperatively or conservatively, how we use it in the OR, and also how we use it afterwards, after the surgery. And where can we use it, or where do we use it conservatively? Mainly in patients which have an arthrosis quite beginning, but also some patients who have a severe OA, because we know that also in these cases we can really reduce the inflammation out of the synovia, because this is a main part of the pain and of the problems of the patients. We cannot treat in these conservative treatments of OR the mechanic problem of that, but we can take care of pain and inflammation due to the reduction of this inflammation. We also use it in meniscal degeneration to reduce the pain, and maybe a lot of patients are not able to do any surgery because of their job or something else. So we can maybe delay the surgery. We can do it for prehabilitation. Also, if we have patients after an ACL tear which are not able to be operated yet because of a problem with the extension or flexion, then you can help reduce the inflammation in the joint, or of course tendinopathy like patellar tendon or quad tendon or the MCL or the runner's knee. We really like to use ACP in these cases. Then other points we're going to discuss later is the meniscus repair, how we integrated this also in the ACL reconstruction, how we help or we think we help the integration of the graft. And we're going to discuss a little bit of cartilage transplantation, the AutoCAD technique. And then post-operatively, we really like to do that because for getting an early recovery, we like to help the patients in the rehabilitation phase to take out the inflammation post-op, how we are going to integrate that. So first of all, conservative treatment of ACP, how do we use that? The easiest way is to make an intra-articular injection where you help to regenerate and to reduce the inflammation out of the joint from the synovia. We like to do that in 3 injections over 3 weeks. The other one is where you can use the ultrasound to make an intrameniscal injection. It's quite easy to do that because, you can see the femur and the tibia quite easily in the ultrasound. And then we know where the meniscus is. You can see the tear of the meniscus because we know from the MRI exactly where the tear is. And then you can focus on that. And you can easily see the needle and put the ACP in here. What you really have to tell the patient before this is really painful because of the pressure which you are going to increase in the meniscus. So this is a quite necessary information for these patients. The last patient I treated 2 weeks ago with that, with this ultrasound-guided intrameniscal injection, is a handicapped patient who plays in the Paralympics. I think it was a basketball in the wheelchair, and he had this meniscus tear and couldn't be treated in the OR. So we did this to reduce the inflammation and help the meniscus to heal itself. Now, the intraoperative use of ACP. First of all, we're going to focus on meniscus pathologies. First of all, how is my setting in the OR? Our standard setting is that the patient's legs is fixated in a leg holder. We always use a tourniquet with a pressure of 250 millimeter. What is this called? I don't know. The pressure is 250. And what is important, if you want to combine this with AutoCAD, we need a higher pressure, about 300 millimeters. Then always the leg holder, for me, very important to reach all of the parts in the joint easily. And then we use the R-Track systems like the Synergy and shavers and all the things you need. And how is the procedure done? First of all, you make your standard meniscus repair. We really like to use the fiber stitch here. Then parallelly, we produce the ACP, which is done in the standard protocol. Here it's necessary to take 1 syringe, and you will produce enough ACP with that. And then when you want to inject it, I like to do that in a dry joint. So you open one portal of the trocar, which is very important, and take the liquid out with a suction. When you don't open one portal of the trocar, you're going to reduce the pressure in the joint and it's going to bleed a lot. So always when you want to do things like this, open one portal of the trocar. And then, as I'm going to show you later, we inject the ACP directly in the part we sutured. And for us, this doesn't change the standard protocol. So if we treat the posterior horn maybe of the meniscus in an easy way, where you have a longitudinal or an horizontal tear, then the people are not allowed to bend the knee over 90 degrees for 4 to 6 weeks. So one first case, it's a 46-year-old patient. We see there are also already some changes here of the cartilage and the medial joint compartment, and with this complex tear here of the meniscus, which was sutured, as you can see here directly. It's quite near of the posterior horn of the meniscus. And then after taking out all the liquid, I like to penetrate the meniscus parts with the needle and then inject the ACP directly into the meniscus. And if you have a rest, then you can put it intra-articular. Another example here is a 30-year-old patient. He came to the practice with ongoing pain over 6 months. In the MRI, we saw a complex tear of the posterior medial horn. That was the first view we had. So you can imagine that there might be a problem. And after resecting some parts of the meniscus, we can see that here's already some degenerative changes with some fatty tissue in the meniscus. And as you can see here, I resected a part of it, took away this destroyed white zone, and then I suture the horizontal tear. As we can see here, I penetrate first the superior part of the meniscus with the fiber stitch, and then the inferior part of the meniscus, because we know from studies that these horizontal tears stabilized quite good. So if you use the fiber stitch, it's important that first of all, before you pull into the loop, that you pull on the whole system to ensure that the little feet of the suture will be directly at the capsula, and then you can suture it, and then again penetrate the meniscus with the needle, and then inject the PRP directly in the meniscus, and the rest is injected into the joint. So you can see it's a quite easy way to do that. What is interesting us always is if this just a nice and romantic idea to do that, or if we really see changes here. And we have some studies here which showed us that we have significantly better pain scores and Lissome scores post-operatively, but the healing rate wasn't influenced positively here. We know that the healing rate is better with PRP than in the control group. Significantly, we know that the re-tear failure rate is much less compared to the control group in the third study. And we know that PRP can lower the failure risk, as we saw already in that study, in isolated repair. What we also know is that if you combine a meniscus refixation with an ACL reconstruction, we don't have any benefit, because we think that a lot of these growth factors already come out when you produce the bone channels. As I told you, we always recommend to do PRP injections after the surgery, and we recommend to do that after 10 to 14 days when we take out the stitches. Because we also know when we do these post-op PRP injections that the failure rate is reduced in this study 48% compared to 70%. And we know that fewer subsequent arthroscopies are necessary due to that. Another study, which also did 3 injections, as we always recommend, saw that the healing rate is a bit higher. Not significantly, but a bit higher compared to the control group. Another study didn't show any significant improvement in pain, function, or return to sport. When I see these studies, I'm always interested how they produce the PRP, but in this study, it wasn't able to find out. And there are other studies with reviews where the results were inconsistent. And here also always the same, like I discussed before, we often don't know the PRP protocols, because there are some other PRP systems on the market where we know that the base rate of the thrombocytes is sometimes lower than in the full blood. So yeah, when you take these, the results won't be good. So key takeaway for this meniscus treatment for me, the strongest effect will be shown in the intraoperative augmentation and isolated repairs. Combination with ACL reconstruction doesn't seem to show any benefit. Then we see that there is a positive data in postoperative injections, but not so heterogeneous like in these intraoperative ones. And as always, it's always necessary to see how the PRP protocols, production protocols are when you read these studies, and you have to be very careful in this. So another very interesting thing, which we also discussed now in the last time a lot with Arthrex, if we can integrate the use of ACP in ACL reconstruction, and I would like to show you my idea of that. As we saw before, how is our setting? The same like with the meniscus. We use the tourniquet, the leg holder, the Arthrex Synergy system, and then the ACL reconstruction is done in your standard manner. So I really like to do in 80% the quad tendon. You can also use the CMT tendon. You can use the patella tendon, whatever is your standard protocol in the ACL reconstruction. And what is important, as I'm going to show you, when you do the drilling of the bone channels, and we like to do that with the flip cutter, then you can easily collect all the autologous spongiosa with the shaver and graft net. And parallel to that, the ACP is produced, and then the joint is dried again through an open trocar portal. And then you mix, as I'm going to show you now, the ACP with the spongiosa, with the cancellous bone. You resect it and then put that into the drilling channel, and then we insert the graft. So seems to be complicated, but it's not. I'm going to show you that now. This also doesn't change our standard post-op protocol. So as we can see here, 31-year-old patient, she fell during skiing, and we see a classical tear of the meniscus. We see the empty wall sign here. And we also saw that there's a posterior medial meniscus tears, which we treated as well in the surgery. So, what we do is when we do the drilling of the femoral and tibial bone channels, we always know that there is a lot of spongiosa coming out of these channels with a high volume of sponges chips. And when we do that, we have the shaver here, and on this shaver we have the graft net adapter, which we also use, for example, for the collecting of cartilage chips when we do the AutoCAD technique. And I like to collect all these autologous cancellous bone in this. So how does it look like when you open that? As you can see here, we collected all of these chips here, which are quite a lot. And then you can take them out easily from that graft net adapter. And also, if you want to combine the ACL reconstruction with an AutoCAD technique, you just have to need or to take one of these graft net adapters to make the surgery not so expensive. Then we produced the ACP, and I like to put some ACP on here, not too much, that our mixture is not going to fall out of the femoral tunnel. And you can mix that quite easily, like when you're baking in the kitchen. And then we fill these mixture into a syringe to easily fill it into the applicator. And I like to use the same applicator here like we use for the AutoCAD technique. And then we fill that in here. Always be careful, otherwise you're going to shoot out everything, as you can see here. And then put the stem forward until you see that the chips are coming out, and then everything is prepared. So how do we continue? As you can see here, I took out the liquid of the joint. This is the applicator, which is quite nice because the applicator is opened on the side, and then I fill the mixture here into the bone channel. And then you are going to enter the graft as you can, or as you do it, as always. And then, first of all, I do that at the femoral side. And then I do the same here, also very nice, because everything comes out from the side of this applicator. You can fill it easily into the tibial channel, and then you pull in the graft normally. And what we just discussed in our group is that we think that we fill out a lot of empty space in these channels with that, and also the literature is going to show that, as we can see later. And then you see here a nice ACL reconstruction where we filled up the tunnels. So if we look into the literature, first of all, we could also put in only PRP in the drill tunnel, which I think is quite not so really easy, because a lot of the PRP is going to come out again. And there are some studies which showed that the integration of the graft into the tunnel interface seems to be better, but that is not a complete positive outcome here. What we see in other studies, which are a bit older now, they show that we have a significant less femoral tunnel widening at 12 months. And there seems to be a better cortical bone formation in the interface in quite early MRI follow-ups. they could show lower edema and higher vascularity. And also the tunnel widening was reduced significantly. There are some other studies which couldn't show any positive outcome when you only put PRP in, and their idea was that maybe the PRP is not going to stay into the tunnel, which I think is a problem. Maybe then it's better to use the ACP or PRP to wetten the graft before you integrate it in, because I think really if you inject it into the tunnel, a lot is going to come out. I think we're going to take care of that. But I think what is more interesting, as I showed you before, this so-called bio-ACL, where we do the PRP and autologous bone augmentation before. And here we have some studies which could show that we have a reduced tunnel widening, we have an improved graft maturation, we have smaller cysts here in a control group. Versus the control group after 6 months, so quite early. But there are some other ongoing studies. There are not so much studies which are already have proven everything. So this is what we are going to discuss now, if it's positive or not. But I think the idea to enhance the biologics will always have a positive outcome. So for me, this is a quite good idea, and I always like to integrate that in my standard when I do revision cases where we really want to take care that the ACL is going to heal. So for me, as practical takeaways, it's very easy to do that. We have some short-term follow-ups which show positive outcomes. We have promising pilot signals in this Switzerland study, but we really have to see what is going to happen. So the next part, which is my one of my favorite surgeries, because I was allowed to treat it very early when AutoCAD came out, is this cartilage repair. And what we do is we have a single stage all autologous cartilage reconstruction, also with the use of ACP. So what we do here is we have a single stage fully autologous cartilage repair, which in my eyes is very beneficial because we don't need any cartilage from the lab to be implanted in a second step. The harvesting and mincing is quite easy. We use ACP as a biologic carrier, what is very logic. And what we know from studies is that we can produce a chondrocyte outgrowth using that technique. And again, why we use ACP here, as I showed you before, we're going to activate the thrombocytes through the centrifuge. And then we have, for example, these growth factors, which are important for the collagen synthesis, for cell growth, for matrix differentiation, which really has a positive impact in cartilage regeneration. Why do we use the ACP as well? You maybe remember university times with this coagulation cascade. And in this thrombinator, we have a borosilicate salt inside. And when you inject the PRP, the ACP in here, you're going to activate the last step of this cascade and then produce this cross-linked fibrin clot. And there are some studies which have proven that what we produce here is very stable against shear forces. So it's really possible to fixate cartilage chips with this ACP. So how does it look like? If you want to fixate that, you take the thrombin glue out of the thrombinator, and then you see here, this is a medial femorcondyl which was treated, which was filled with the cartilage chips, and then you fixate it with that. So a little case we can go through. This is a patient which has a problem in medial femorcondyl. He has an edema beneath this defect, so something we should take care of. And then if you still have some good cartilage left, you can take that for the transplantation. What we know from studies that the cartilage quality, the vitality of cartilage from the defect border is very high, so it's always good to resect that from the border. You can also use curettes or sharp hooks for the debridement, and we want to transplant the cartilage afterwards on the subchondral layer here. So the part where the cartilage normally belongs. And so you can use the curette, as you can see here, and then put the shaver in and resect all of these cartilage chips. And also, if you enlarge the defect about 1 millimeter on these borders, you will ensure that you have a good quality of cartilage chips you're going to retransplant. And as you can see here, it's the same mixture idea as we saw before with the mixture of the autologous bone in the BioACL, and we mixed here the cartilage chips with PRP, and then you fill the defect here, and you only are allowed to fill the defect. Here you can see it's with 2 defects. You are only allowed to fill the defect 50 to 80% because otherwise you will have an overgrowth of the cartilage. And as you can see here, also if you treat over the top positions, because the ACP you used for the mixture with cartilage chips, which is also adhesive, you can easily treat this over the top areas also, like for example the kneecap. And then everything is fixated. You take out the thrombine out of the applicator, and then you fix it. And you're also able to move the joint after that because you produce a quite stable cartilage tissue which you implanted. So the rehabilitation protocol for AutoCAD, if you treat weight-bearing areas like femur or tibia, depending on the size, it's 2 to 6 weeks unloading or partial loading. The range of motion is free after 48 hours of immobilization. We always recommend to use the CPM post-op. If you treat trochlea patella, it's not so bad for the patient because normally they only use the crutches for 2 weeks with half body weight. And the range of motion is restricted over 2 week steps in 30, 60, and 90 degrees, but they are allowed to use the CPM directly. Cycling and swimming with crawl is allowed after 6 weeks, and in backloading 8 to 12 months, depending on the size. And you can see here an example. I was able to rescope this patient after 5 years. And I think this is really impressive. This is a football player. He returned completely to his high impact sports, to the 3rd Bundesliga. And I really think this is really, really impressive how the cartilage looks like. And we treat a lot of patients here, and we are going to publish our 5-year data. And I'm going to show you these 5-year data already now. And when we look into the areas, the defect areas which we treated, then most of these were the medial femoral condyle, something we know that often here we find our cartilage problems. At the lateral femoral condyle, 22%, patella 21%, and the trochlea 14%. And then the size was at the medial femoral condyle 2.2 square centimeters, in the patella, in the trochlea, the biggest defects. These are quite small defects because when we started to do this AutoCAD technique, we started with smaller areas because we weren't sure if it's going to work. But now we saw that you can also treat more or less all of the femoral condyle because we really produce a very stable cartilage transplant, and it's not necessary to fixate it with any membrane or something. And then if we look over these 5 years in the pain score, we see that preoperatively the people often have a lot of pain also because of the bone marrow edema, and then post-op it's going to reduce very fast, and the pain reduces significantly over these 5 years. If we look into the core scores, the core score is very important for us treating the knee. Also the coarse knee score goes up very nicely, and we can also improve it significantly, and also the symptom score improved significantly. If we go into the score with activity of daily lives and quality of life, we could also show that over these 5 years, it's going to get better. We compared these also to ACI from our center, and we could show that there are no significant differences between it, and the AutoCAD outcome is more or less the same. In the functional outcome, it seems to be a little bit better, but not significantly. And from the technical activity score, we could also show that we can reach initial levels after 2 years again. And what I think is really promising, because this is what the patients want to know from us. And if we look into the literature, then we know that the results are quite good. We only have 1 5-year follow-up from Gian Salzman, which is an open manner, and we are going to publish it maybe in the cartilage paper where we just sent our study. And we already published our 2-year data, which are very good. And there are some other smaller studies which could show that, it's very, very promising technique. So practical takeaways for AutoCAD means cartilage. The outcome is comparable to the established techniques. The gold standard in Germany is ACI, where we know that the long-term results are quite good. And the results we have seen now are comparable. ACP is for us very important because we want to use these growth factors to ensure the healing. And what we also know is that in other joints, some of you told us that you also treat ankle or shoulder. You can also use this in these joints. And the revision rate is very low. And we saw that the main problem is a graft hypertrophy. And this is because when we started with this, we were very proud, harvesting a lot of cartilage. So we filled the defect completely. And we know that this is a mistake. So you're only allowed to fill the joint 50 to 80%. And since we do that, we more or less don't have any hypertrophy in our follow-ups. And some studies here. So thank you very much. This was my overview, and I'm happy to hear some questions.
Thank you, Dr. Schneider. Dear experts, if you have some questions, please ask.
Yeah, absolutely. I have a question. My first question is, do you think that then you inject an ACP at some patients with a small medial meniscus tear? Do you believe that injection of ACP can help this patient avoid surgery at all?
Well, it depends really on the meniscus tear, right? What we know
absolutely. I mean, a little tear of posterior horn, maybe it's painful. Of course, you have some positive symptoms, etc. But you will inject in ACP, and the complaints reduce. An awesome condition. I have a lot of this patient, but I'm not sure that, for example, after 3 or 4 years, 5 years, maybe they will return me to the surgery. What do you think about it?
Yeah, that's true. But this is what I just wanted to say. It depends on the type of meniscus tear, because if it's one who really mechanically disturbs the knee and where the white zone is also part of this tear, then ACP won't help healing the meniscus. It's just going to help you reducing the inflammation from the synovia, but it's not going to help to heal the meniscus, because in the white zone it cannot heal. And these are the typical patients which you see after some years, because the pain reduces, what we know from meniscus tears, and then they come back and then have bigger tears and they have cartilage problems. So when you decide which patient is the conservative one, I think you really have to take care of that. But I think you can help the patient to reduce the inflammation, increase the healing, but it really depends on the meniscus tear.
Okay, and second question, I think it's very important for me. Of course, the standard post-operative protocol include non-steroid anti-inflammatory drugs. It means that it can really reduce the effectiveness of ACP. What do you think about it? Maybe you have some different protocol, and please share with us.
Yeah, so that's true, but so normally we only recommend to take Novalgene, for example, and no ibuprofen or something of these pills or drops. But what we know is that also if patients take their standard medicine they receive from other doctors and they're going to continue with ibuprofen, for example, it still works, because I think when you inject it intra-articular, I'm not sure how many of this ibuprofen, maybe this is the main pill in Germany, is going to come into the joint. I think it will reduce the outcome a bit, but I don't think there will come so much inside that all of these properties will be reduced or will be taken out of the joint. Because in Germany, they all take these pills and you still have this effect.
Okay. How long do you use ibuprofen or maybe paracetamol or something like that? 1 week, 2 weeks, 10 days?
After which procedure?
After injection into the meniscus. I mean, after surgery.
Well, it depends on the pain of the patient. We recommend it for 1 to 2 weeks. But if the patient has no pain, normally when you do the injection conservatively with ultrasound in the practice, then it will be very painful. But after surgery, if you inject it, the people normally don't have so much pain. It's different. And then they just take the painkillers for 3 to 7 days normally after a meniscus refixation. After ACL, it will be longer.
Okay, and last small question about meniscus. What kind of needles, for example, standard green needle or maybe from insulin syringe or something like that? Because injection into meniscus is very painful.
You mean in the practice or in the OR?
Yeah, in practice, yeah. You take the insulin syringe, take the needle from that, and use it for injection of plasma.
Yeah, it's just a normal needle. There's nothing special. It's just a normal needle. What you can do is, if the patient is really, really painful, then you can do a little bit of injection of anesthesial things into the skin to reduce it a bit. But main part of the pain comes out from the meniscus, from the pressure you put in there with the PRP.
Okay,
but it's just a normal needle. It's no special syringe.
21 green one, 21 gauge.
Yeah.
Because my message to all experts, if I have the procedure like that, I take the, for example, 2 milliliters syringe with a little blue one needle, or I take insulin syringe with a very small needle and perform the injection through that needle. It's much more better and easy for surgeon and for patient. Okay, thank you.
But sometimes through the insulin needle, it's too very hard to get all of the liquid in.
Yeah.
It's better for the patient, but yeah.
Other experts? Questions? Daria, Anastasia, Victor, Anna?
Yeah, hello. Yeah, Stefan, thank you very much for your presentation. It was excellent and you have a lot of experience, and it's really nice for me to see the result of your surgery after 5 years. It's excellent, yeah. And I have a question about the using ACP in pregnant women. Do you know, can we use it or no? Regular it or no? Because I have now a patient who is pregnant. It's about 25 weeks, and I don't know about could we use ICP for this kind of patient or no? Thank you.
A very good question. I never thought about that, but I think it's possible, to be honest. I would ask the Arthrex colleagues, maybe, if the bio colleagues, if they know it, but I don't know why this should be a problem. The only thing is inflammation, maybe, but I don't think why we shouldn't be able to do it. But I never thought about it, to be honest.
Okay, yeah, I think that, yeah, of course we can because it's autological, but I'm not sure that if we have some problem, it's regular.
Yeah.
Yeah, and yeah, of course, it's more question for Artrax manager, maybe.
And maybe they know it, yeah.
I will clarify. Okay.
Okay, I have one more question about ACL.
Dr. Kalmakov, sorry, Anna was Betts was trying to say, but she was muted. Dr. Betts, you are muted. Please unmute yourself.
Okay?
Yeah,
It's okay.
yeah,
Yes, we can hear
Okay,
you.
it's okay. Thank you so much for your presentation. And I have a small question. If you had the choose between using ICP techniques or PRP by Angel system, which technology would you choose and why?
Well, in our practices, we only use the ACP because we had the Angel centrifuge before, and we tried to use different protocols with the leukocyte rich and poor, and we couldn't see any difference. The idea in the beginning was that maybe tendinopathies, Achilles tendon or something, which we would be treated better in another leukocyte concentration, but we couldn't see any difference. And so it's much easier and cost efficient to use only the ACP syringe or the ACP system. We don't have the Angel centrifuge anymore.
Okay, thank you.
Yeah, but
More
for
question?
Russian, it's this. No, it's not. It's more about comments. In Russian, we have the same price for 3 syringe of ACP and 1 set of Angel PRP system. And sometimes we have a question, what we have to use for patient? What is the better when we set about the practice, using in practice for conservative osteoarthritis? One injection of PRP of Angel on 3 PRP of ICP.
Yeah. So we only use the Angel system in the OR and then sometimes in the practice, but it was so much, time changing and cost changing, because in Germany it's also more expensive, the Angel system with all the systems you need, and so we didn't use it anymore because also the time is a big difference. And we couldn't see that there is a positive impact when you choose the different concentrations of the platelets and so.
Okay, now you prefer the ACP, yeah?
Mm-hmm. Yeah.
Okay. And I have one more question about mucoid degeneration of meniscus. Sometimes we see it combined with meniscal root tear. And I see that the quality of the meniscal tissue is low. And I see the mucoid degeneration inside the meniscus. And how you think it's better to use ICP during the surgery inside the meniscal tissue, or enough if we fix the root tear? Because we have the mark from the bone tunnel.
Yeah. Also a good question. So in these cases, I think the main important thing is to refixate the root, because we know biomechanically, if there's a root here biomechanically, it means for the joint as if there wouldn't be any meniscus left. So it's important to refixate that. And often in these women, mostly women, the tissue quality isn't so good. But I think the bone channel is much smaller than we produce during the ACL reconstruction. So in these cases, I really like to do the ACP injections post-op. In these cases, I often don't do it during the surgery, like when I fixate in horizontal tear or longitudinal tear, because then, as you told, we make this bone channel. this drilling, and I only make the ACP injection post-op after taking out the stitches after 10 days.
Oh, thank you very much. And when you start using ACP after the surgery?
Well, 10 to 14 days when we take out the stitches. And then some patients still have some inflammation inside, some liquid inside, and then you can help reducing that. And what we also want to do is to reduce the re-tear rate.
Okay, thank you very much. And after that, I have one more question about using ICP for chronic synovitis. Do you use PRP to reduce the synovitis or not? Or what about your experience?
Well, yeah, we use it, but the results are not very homogenic. It's really, some patients have a positive impact and some others don't interest. The knee isn't interested if you inject it or not. So often in these cases where it's really chronic, I think it's more effective to send them, I don't know the word in English, we inject this radioactive liquid which is going to destroy a part of the synovia. And these patients often, they have better results than injecting ACP, but we often start with ACP, and some have a positive impact, and the ones who don't have a positive impact, we send to the colleagues who do these radioactive injections.
Oh, it's really interesting. And how it's called in German?
Radiosynoviothesis.
Okay, yeah, maybe we have the same in Russian. We need to check it. Okay, thank you very much for your answer. Yeah, it's really interesting to share our experience with you. Yes, thank you.
I have
I'm sorry.
Anastasia, you're okay. You're welcome.
One question, please. Dear Dr. Stefan, thank you for your presentation, for work you did. I have one question. When you demonstrated technique of AutoCAD in knee, you didn't use microfracturing.
No.
Didn't use. It's not important for this technique.
No. No, it's not. You shouldn't really do it because we want the cartilage to heal directly on the subchondral border. And in the beginning, you think, okay, if I do this microfracturing, maybe it will hold better, or maybe the cartilage will be supported from the subchondral bone. But it's not necessary because you're going to produce osteophytes, and you won't produce any better healing. And we also have some histologic views post-op where you can see a very nice integration of the cartilage into the bone. And it's not necessary to do any microfracturing. It will have a negative impact.
Oh, okay. It's very interesting information because when we implantate collagen membrane, yes, we use microfracturing because it's not.
That's a Macy technique, correct? Yeah, correct. And we do it as well, but we don't use it anymore because we know that the AutoCAD techniques, the results are quite good. In the Macy, we also have already 9-year, 10-year results, which are very good. But we see that the quality seems to lower up over time. And in these cases, we do it as well, but we don't use any Macy and ACI anymore because we see so good results. And an AutoCAD technique takes 15 to 20 minutes if everyone in the OR knows how to do it. And and we know what is quite interesting. If you take the cartilage out of the defect border, we know that the defect border has to take a lot of load, so the vitality is very, very good. And the cartilage chips you use for the reimplantation are used to the pressure they need. Because if you go, for example, to the notch or to the femur border, you can also harvest the cartilage there, but the cartilage chips there have never seen any pressure. So they have to dedifferentiate to shear loading cartilage. And if you take it out of the defect border, they already have the perfect differentiation. So it makes sense to take them out there. Yeah, it's really interesting.
Thank you so much.
And do you use the curettage or not? the deep of the defect?
It depends on the defect. Sometimes it's enough to use the shaver, but sometimes it's useful to use a curette. And I always like to use hooked curettes. So if you treat the femoral condyle or so, it's easily to reach all of the parts without changing the portals too often.
Okay, thank you.
Okay, my question about ACL and ACP injection into the bone tunnel. Because then you're drilling a tunnel, you have a lot of bone marrow. It's not concentrated, of course, but it's bone marrow. It's full of different things. And do you believe that we have, for example, incorporation of our graft along the tunnel, or we only trying to avoid the tunnel widening, or maybe some analysis about the graft?
Yeah. So when you look into the literature, and also when we look into our own cases, where we always want to do a press fit integration. So in the beginning, I thought maybe we don't need this bio-ACL because we have such a press fit integration of our graft into the bone, but we still have cases which widening of the tunnel. So there might be anything which disturbs there. And this is why we thought, okay, maybe we can reduce these percentage even more when we inject this PRP or we inject this spongeous bone in combination with ACP, because we still have these cases, and this is why we do it. And I agree. In the beginning, I thought it's not necessary to do all of this, but then we discussed it, and we still see in our outcome that there are tunnel widenings, and we want to reduce these.
Okay, in other words, you await better results 100% with injection of ACP, even if you're using a graft tube for very, very press fit fixation. It's better than drilling only. Okay, thank you. It's very important.
I cannot tell you yet if it's just an idea. It's just where we started to take care of, but I cannot tell you. Maybe we're going to say in 2 years we never should have taken any blood from the patient because it's not necessary. I cannot tell you, but we still see these cases where we have this integration or this widenings or integration problems. So yeah, we'll see over the time. Yeah.
Dr. Schneider, if I may, could I have a couple of questions? I know that we are a little bit out of time, but maybe somehow very briefly. About AutoCAD. I'm not asking about maximum size of cartilage defect, but let's say what size of defect you will treat confidently from your current experience.
Well, the biggest defect I treated was a radiologist from Hamburg who is completely crazy because he does. He had more or less all of the medial femoral condyle was gone. And here we did the ridge repair. We recommended an HTO, which he didn't want to have because he wanted to run very fast. And we transplanted all of the femoral condyle. And he went to the MRI, to his own MRI every 2 weeks. So we had a very nice follow-up. Yeah? And this was very interesting because it works. After 2 years, he had a little gap at the anterior border of the transplant, but the main load-bearing area was completely good. So this was the biggest defect you can treat, because we know now that it's not necessary to fill all of the defect. You will always get enough cartilage to transplant. Even if you have, for example, a lot of patients with ACL tears have a cartilage problem, medial or lateral condyle plus trochlea, and you can also treat these bifocal or trifocal defects.
But I mean, what's also not like average, but which maximum size? If you see it, you are confident that it will be treated very well with AutoCAD. And if it's higher, so you have some kind of discussion. Is it worth to treat it without AutoCAD or not? So somehow, which size of confidence do you have for this damage?
You mean, I don't understand the question, the maximum size of the defect or what?
So which size are comfortable for you to treat a patient with cartilage defect? I mean, from your current practice, or like any size of cartilage defect, you will treat with AutoCAD with high level of confidence. Or there is some limit of this size.
Yeah, there are some recommendations which cartilage technique you should take for which size. But we see that, as I told you, from our experience, and we use also MACI and ACI, and we see now that all of the sizes can be treated by AutoCAD, also without covering with the membrane. So you want the defect. If you have a very, very big defect, like in the radiologist, you sometimes have to take some cartilage from the notch or from the femoral borders, but you will always have enough cartilage to treat that. So this is no discussion for us anymore.
Okay, thank you. And maybe a couple of words about your practice and application of fibrin clot for meniscus treatment during surgery.
Yeah. We used to do that in the beginning a lot, but what we know is that the fibrin clot you produce sometimes gets liquid again over the time. So in our idea, we don't use the thrombin to glue it, because I think you won't produce stability which is with this thrombin glue, which will be enough. So it's important to do the sutures. And then it's more important to glue that again, because if the suture is not going to hold, the glue won't do anything with a positive impact. So it's more important to enhance the biologic healing. So this is why we don't do this fibrin clot anymore. Also because in Germany, the patient would have to pay it themselves, and often they are not interested in that. But in our hands, I think the injection of ACP is more important than to glue that on top of the sutures.
Clear. Thank you so much. So we are out of time a little bit, and I highly appreciate your time, sharing of your knowledge. And I think if other physicians have some questions, please share with us, and we might organize another session to discuss some other things. And for now, I just wish everyone to have a good evening, and thank you all one more time a lot for your time, passion in bio, and being here with us. Thank you so much.
Thank you.
Thank you so much. Thank you. Good evening.
Bye-bye.
Thank you for all participants. Thank you.
Bye.
Bye.